My name is Kenneth TT. My background is kind of diverse. I have an MD and an MBA, and really I've always been focusing on health technology. I completed a fellowship in clinical informatics at Harvard, and right now I'm a lecturer and research scientist at Harvard and MIT, the Division of Health Sciences and Technology. And I'm also the Director of Operations for Sana, and you'll hear a little bit more about what Sana does in a little bit. This is a brief outline of what I'm gonna try and cover today. I know everybody might have diverse backgrounds. Some of you are more on the clinical side. Some of you have a little engineering and technology side and business side. So I'll just try and do a little primer to get everybody a little bit of your toes a little wet within this area. Then I'm going to talk a little bit about mHealth or mobile health in the context of health solutions, the evidence and the benefits thereof. And then I'm going to give you an overview of Sana, specifically the type of work that we do, specifically within global health informatics. And finally, I'm going to give it an overview of the various projects that we're engaged with, so you can get a little taste of what mHealth can do within healthcare. So, to set the stage, one of the key acronyms that you're going to hear within mHealth is Information and Communication Technologies, or ICT. Essentially, this is any technology or technologies that facilitate communication. So, computers, phones, internet, wireless, all these things are within the realm of ICT. So, kind of straightforward, but also very broad and very general, kind of ambiguous. One of the specific things that you have, probably most of you have in your pockets or purses, is a cell phone. I just wanted to go through a brief range because within the context of mobile health, you have to know what platform you're delivering to. So at the most simplest level, or the bottom level, which is on the top here, you've got your dumb phones. This is the traditional phones. Starting around 1997, you had your heavy Nokia phones that were indestructible. And you were able to do voice calls, get SMS phone messages and such. And then just a little level above that, we're terming feature phones. And this is basically in between the dumb phones and the smartphones where we're at today. So many of you might have an iPhone or an Android phone, and that's at the high level. Those are smartphones, and you're able to do custom applications. You have your screens, large screens, touch screens, and you can do a lot of graphical and visual displays and interactions from a computer perspective. The feature phone is the middle tier. So, early 2000s, you had feature phones that you could do some basic programming. They had some games and stuff that you could do on your phone. And the reason I highlight it here is because within global health, specifically and research for limited lower and middle income countries, feature phones are very prevalent. So a lot of global health solutions are actually targeted for feature phones. You can do a little bit more than just straight SMS. You can do some data collection, little text entry that you couldn't do with just the basic dumb phones, but it's not as advanced as smartphones. But then it's also cheaper than smartphones, so that's why it's there in the middle tier. Something to think about for your mobile health solution. So, just to get you engaged and start thinking about this, I wanted to open up with a little exercise. What are some examples of ICT, information communication technologies, that you've used in your life, in your daily life? Raise your hands. It looks like you're going to raise your hand right there. Yes. Cell phones, computers. Good. TV. Yeah, absolutely. Phones, tablets. Excellent. So most of you have used it. Raise your hand if you've used an ICT in the last week. Everybody, has anybody not used an ICT in the last week? Okay, great. So yeah, it's very ubiquitous. It's everywhere, and most of you are comfortable with using it. So the idea is maybe we can use these to improve delivery of care and interactions and things like that. Now this is the complicated slide. It's going to be a lot of information, a lot of acronyms, a lot of whatever, a lot of complicated terms. Don't be overwhelmed, but I want to introduce it that health IT is very broad, covers a lot of things, but yeah, don't be overwhelmed by it. I'll try and explain it as well as I can. And in essence, they're just synonyms. You get the essence, and the essence is that, you know, computers in healthcare. That's essentially what it is. So, you know, you have e-health, you have m-health, you have connected health, you have digital health. They all kind of mean the same thing. I'll try and dive a little bit into specifically what m-health is. But within that e-health arena, you know, that's usually the blanket term for all health IT. You have enterprise level, you have clinic level, practice level. So you have electronic health records. I'm just going to throw out terms and hopefully you recognize some of them. I wouldn't expect you to recognize all of them, but so you have your electronic health records, you have your personal health records, nurse information systems, lab information systems, PACS, which is the radiology information systems, computerized physician order entry. So if you're a clinician and you're writing an order within your system to tell you know, what the treatment recommendations are for nurses, e-prescribing if you want to do a digital record and transmit your prescription for any type of pharmaceutical to the pharmacy, and also back offices within the realm of this within eHealth. So you've got your administrative work, your registration, billing, all that is included within the realm of eHealth. So as you can tell, it's basically anything. Computers in healthcare is what health IT is. Now, to confuse things a little bit, my fellowship was in clinical informatics, and that's essentially, you know, computers within the hospital from a clinical perspective, clinician's perspective, and that falls under the umbrella of biomedical informatics. So informatics basically is an information science, the transfer of the way that information travels within some area. So biomedical informatics is the umbrella, and then there's a whole bunch of subdivisions. You've got your public health informatics. So really, if you've got public MPH or public policy, or if you're engaged within the public healthcare system, you know, citywide, statewide, nationwide, you know, these types of information you want to keep track of. So these are like disease surveillance, disease outbreaks, things like that. Translational informatics is, you know, you hear all the things about gene sequencing, the Human Genome Project, and all that, all the tons of data within the human genome. That's translational informatics. Clinical informatics is, you know, the clinical practice of medicine. That's where I sit. That includes decision support. That includes EHRs, and then imaging informatics, which is, you know, all the radiology images. So that can be the analysis of the image, or it can be the decision support within that image. And what you'll notice is, even within this, within across the board, the spectrum of informatics, it actually crosses all the areas within eHealth. So that might be a little confusing. It's not too important for the rest of the things, but I think for most of us that are within the treatment, specifically for behavioral health, you'd be within the clinical informatics domain. And because we're going to talk about m-health and telemedicine, I wanted to just touch on telehealth and telemedicine. I'm sure you've heard of those terms. I just wanted to note what the distinctions are. Obviously, they're essentially synonyms, but telemedicine is a subset of telehealth. Telehealth is broad. It includes telemedicine. It also includes e-learning and training and tools like that. And essentially, anytime you have tele in front of health or medicine, it means distance, basically a long distance delivery of healthcare. It could be simply over a phone, or it could be over the internet. It could be a video conference. It could be store and forward data, meaning you're capturing data one place and you're transmitting it to a clinician or another healthcare provider. And you know, one of the big components is using wireless communications to facilitate that. And then telemedicine specifically, as I mentioned, is almost synonymous with telehealth, but it focuses on the clinical services, the delivery of clinical care. And then there are categorizations of telemedicine, including teleradiology, telepathology, teledermatology, telepsychiatry, and teleaudiology, for example. Any questions? Am I moving too quickly? So, what are some health IT tools you might have used in your practice, or that you might have interacted with as a patient? Maybe you went to see your primary care doctor and they used some system.
When they're getting to know you, the demographics.
Demographics.
In the admissions.
Yes, admission, yes. The back office. Definitely, you need that patient information. Very important for informatics to track appropriate treatments and stuff like that. Good.
Medication lists
Medication lists.
and access to drug information databases.
Yes.
For information about the medicine being prescribed.
Especially with contraindications or adverse events, or if you have any drug allergies, that's definitely something that comes into play with the informatics perspective. How about within your own practice? If you,
As a patient,
yeah, as a patient.
you have a procedure and the doctor would check what is necessary to do and the problem.
Good. Patient education, absolutely, definitely important for to take the patient engagement.
Say as a patient, our physician allows us to have access to our records, so we can see our records and the medication prescribed.
Yeah. Patient portal, patient health record, definitely useful. Especially if you're transitioning from one clinician to another clinician, it's good to carry that record with you. So you keep an electronic record of all your patient encounters. Do you find it useful, or do you find it redundant work, like you're typing too much? Useful? Good. Exactly. Good. So you're already thinking about what we're talking about next.
I worked at
Yeah, great. So it's definitely good to have your digital record, especially if you have separate clinics in different locations, traveling between, or patients traveling between, and you have more than one provider. So definitely e-health has its place within healthcare. So specifically about mobile health or mHealth, essentially it means mobile devices in healthcare. Now this is a subset of e-health because obviously e-health includes all the enterprise systems and just the computer-based system, but it's essentially equally diverse because mobile device can mean almost anything. It can include consumer and digital health. For example, you've heard all the new devices within the tech startups like Fitbit, Nike Fuel Band, and whatnot, and all the various activity sensors. We've got telemedicine that we're talking about. Another thing that mobile devices can be used is for data collection, whether that's streaming or store and forward. It could be used in surveillance and screening, data collection, decision support. It could be used for education and for basically strengthening guidelines and such. So what I want to emphasize is mHealth is not just a single solution. I'm going to talk about some of the solutions, but there's even more solutions out there. So I don't want you to, when you hear mHealth, don't limit yourself with thinking, oh, well, this is how it was used in one place, but it doesn't fit my workflow, so it's not usable within my practice. I want you to understand that mHealth is very diverse, including a lot of different workflows, a lot of different technologies, and we're promoting that it can help overcome certain limitations and improve access and improve quality of care in certain areas. So, to talk about why we're promoting mHealth, and it's essentially what its potential benefits are. Now, we're not saying every mHealth solution inherently has these benefits, but if it's designed correctly and implemented and usable in your area, these are some potential benefits that you can directly observe within your practice. So the first is you can expand your practice model. So instead of just thinking within your clinic, having all your patients come in a single clinic and having them wait in the office and having a limited set of office hours and appointment schedules that you can do and the number of days, all the overhead of the administrative staff that you have within there, you can potentially shift some of that work, some of the more repetitive work or less interactive work to offsite, so you can spend and improve the efficiency of your practice. For one of the ideas theoretically. Another thing is to increase access. So some of your patients might be less mobile than others, whether it's because of illness or because of age or health condition, or maybe they're just maybe you're in a subspecialty that is very specialized within a region, and the patient that's seeking you actually lives many hours away. You might want to be able to provide care to these populations. Mobile health, as you mentioned, as many of you mentioned, all of you mentioned, you have used ICT previously. And the idea is if the patients actually use the system, you can actually engage them within their treatment. So instead of just having them come in 1 week and then come in next month, you can actually engage them either every day, every week, something a little more interactive so that they're more engaged in their treatment. And as you well know, if the patients are more engaged in their treatment, they have better outcomes in the end. Using these mobile technologies, you can streamline data collection. So what that means is you're capturing information between visits for one thing. Another thing is if you're interested in research, or if you want to evaluate an intervention, or if you're doing a clinical study, these mobile technologies can, you're able to collect data more easily, rather than having to require all the patients to come in and collect data at that point, and having a research assistant at the same time to collect that data. And finally, penultimately, if all these work together and it's well integrated within the system and you have a strong evidence base, the ideal, and the patients are engaged, the ideal situation, you're improving the outcomes, that they're going to enter treatment and recovery better, with better outcomes, and at the end, be healthier at the end, and hopefully at a lower cost. Lower costs is kind of self-explanatory, like readmission rates is one of the primary things that you're reducing, but then also administrative overhead and other costs, incidental costs. So now I'm going to talk about Sana specifically. We're not solely in the behavioral health area. We're more general, and what we focus on is global health informatics for rural and resource-limited settings specifically, using technology and innovation to improve quality of care. We want to democratize access, so even the poorest of the poor can receive quality care. We want to democratize knowledge. We want to share information, open source information, and the best practices. And we also want to democratize networks so that we can connect people that don't normally have access to these valuable mentor and professional networks, so that they can really drive the solutions from the bottom up. As I mentioned, this is a project based at MIT at the Computer Science and Artificial Intelligence Laboratory under Pete Solovitz. primarily for the software side. And these are the learnings for what we've come across, or the driving reasons behind what we do. First is that basically the underlying message is, even though we come from MIT and, many people think of us as just technology nerds designing technology for technology's sake, the bottom line within healthcare specifically, technology alone is not enough, right? You can't just drop in a $2 million MRI machine in Uganda and expect them to improve care within that region. It has to be customized and specific to that region. So some other lessons learned is that improved access doesn't always lead to better health outcomes either. And what this means is within the regions, oftentimes it's poor quality of care that is resulting in poor outcomes. So you need to bolster the underlying system to improve the quality of care delivered as well as increase access. So here are a couple studies, academic journals that support what I just said, specifically talking about patient safety in developing countries. First, this slide shows that the majority of adverse effects in developing countries or low resource settings are preventable. They're usually therapeutic error, diagnostic error, or operative error, or surgical or post-surgical infection. These are all preventable by improving the quality of the care that's being delivered. And this came out of the same British Medical Journal article that it's not just resource limitations. It's not just a matter of throwing money at it. You have to improve the underlying system and processes in order to really improve care. So you really need to convert the system, engage the people on the ground that's actually delivering the care in order to improve care delivery. Here's another article from the World Health Organization, again emphasizing the same point, that medicine use within the developing countries, even though they have the medicines provided usually by foundations or aid organizations, 50% of the time they're being misprescribed. So they need better education, they need better guidelines, better training and support. So our mission as an organization really is sustainable quality improvement. We don't want to just increase access, we want to increase access to quality care. So we need to really train the clinicians, support the clinicians, and transform the system. And it has to be sustainable. Healthcare is expensive, right? So we've got the percentage of GDP within the US is huge. It's like 15 to 20%, I don't know what it is, but every year it's growing, it's outpacing the money we're making. So we need to find a way to sustain it, especially for the poor, right? So the wealthy, they're always going to get care. They're always going to have private care. They're always going to get good quality of care. But the poor are the ones that kind of lose access to quality of care. They get, a lot of people don't accept their insurance, or sometimes they get the less trained clinicians. So we want to bolster from the bottom up and find ways to make it sustainable. So we do specific approaches for focusing on evaluation and outcomes, and then also alternative business models, so that because generating income is one way to make interventions sustainable. The core tenet that we approach is that geniuses are everywhere, and we need to nurture them. They're not just located at the academic, centers or the highest academic centers. They're actually everywhere, and it's all usually just a matter of giving them exposure to the education, the knowledge, and the networks, so that they can actually foster innovation at the ground level and democratize these opportunities. So to do that, we take a unique three-pronged approach called 3 C's or whatever, specifically around collaboration, co-creation, and capacity building. So collaboration means we bring together a multidisciplinary team, specifically, even though engineers, the data scientists, the computer scientists, clinicians are crucial, obviously, And then we also want to bring in the business folk, the patient perspective, all these together to make sure we're designing a holistic solution that works, both on the clinical side, but then also on the technology side, and then also inherently the sustainability side. We need to bring all these teams together at the earliest stages so we can have a design thinking approach for any solution. The second, co-creation, meaning we're not just going from whatever academic center. So I'm in Boston. I'm Boston-centric, but any solution designed in Boston doesn't necessarily apply or transfer to other regions. You need to have a co-creation approach of bringing together local stakeholders as well, people that know the problems within the area and understand the workflow. So that's another important aspect. And third is capacity building. We want to be able to train the local capacity, the local engineers, the local clinicians to be able to design and sustain your solutions as you go on. So to do that, we have three major initiatives, one being a technology software solution, the second is education and capacity building, and third is a project incubator. So we have under active development under the MIT CSAIL is an open source mHealth solution. It's an end-to-end telemedicine solution using a smartphone in the front end, a dispatch server in the middle tier, and then electronic medical record in the back end. What that means is we're using cell phones to help deliver care, and it's all open source so that we can, in some ways, attempt to reduce the cost of access for care in these resource-limited settings where you can't afford a $2 billion Epic system to deploy. And with an emphasis on open source software and collaboration to with the exchange and interoperability between the systems. And the idea is to make it a highly flexible system, and it can be customized based on a diverse set of clinical workflows. To that end, we want to make sure that there are design tools built in place so that the clinicians don't have to heavily rely on engineers to build the solution. So, currently, you have to make any changes to, for instance, your Apple app that requires teams of engineers to do code changes. But the idea is to be able to make it easier for clinicians to alter protocols and interactions within the app. So the smartphone component can be flexibly customized, as I mentioned. You can implement guidelines or protocols. You can implement decision support, so you can do recommendations if you have some input, like if the patient has a high hemoglobin A1C, which is an indicator for diabetes, you can make some recommendations or interventions based on that number. You can also integrate with point-of-care devices. So you have a smartphone, it can do a lot of fancy things, it can do a lot of calculation. It has a little plug in the end, and you've seen it interact with various devices, whether it's like an external battery. In this case, you can interact simply with a USB cord to external devices, whether that's EKG machines, so like heart monitors, or some other custom devices, EEGs, electroencephalograms for brain waves, and things like that. And the strength is we're able to process physiological signals. So as opposed to just feature phones where you're essentially just doing data collection, simple guided text field, quantitative measurements, we're able to leverage the computing power of the smartphone to capture complex physiological signals and actually interpret and analyze them as well. For our educational initiatives, we're really focused on training the next generation of global health informaticians, and we specifically take a multidisciplinary approach. No, that's not what I'm talking about, but that's a good point. So when I'm talking about flexibility, is that the Sana mobile platform, the Android client specifically, can be customized and flexibly deploy and interact with various systems, whether it's customizing the guidelines or treatment recommendations, or customizing interfacing with a various device. What you're talking about for cross-platform, there are technologies that do that. Currently, it's not. There are a lot of commercial products that do that. Kind of a tangent, but so like there's PhoneGap, I think is one. There's Corona Labs is another. So there are technologies that allow you to develop once and cross-deploy. But we're and in essence, that's what the Sana Mobile does as well. This is diving into a little more detail than maybe you're looking for, but so what I'm talking about for flexible deployment is customizing it for any type of workflow or any type of intervention that you're considering using the same platform. Does that answer your question? Not really? Yeah.
I mean, I get why you're not.
Yeah. Yeah, so flexibility within deploying a wide range of platforms. We do have separate apps for Android, separate app for iOS, so we can deploy to both. And actually, developing a single protocol that within the Sana mobile platform can deploy both automatically to the Android and iOS. If that answers your question a little bit better.
Use any policy certification
We use primarily the backend is very flexible. We're able to integrate with any electronic medical record system. We generally, for most of our projects, partly driven by partners. The implementation partners we have is we usually implement to OpenMRS. So each of those open systems deal with their own type of certification for meaningful use and whatnot. So the front end doesn't need to go through that ONC certification. It's getting hot, huh? Yeah, I got it. Thanks. Okay, so back to the educational initiatives. At its center point, we have a course at MIT that's run in the spring, and it's a project-based course. We bring, I'll touch that a little bit more. We have mHealth workshops, specifically, for example, this workshop just talking about exposing mHealth, and then we also have engineering boot camps. Okay. And then also next year we're going to be transitioning to an MIT massive open online course. So running out of time, so let me just touch very briefly. Basically, we have our network in Boston, and then we also have a network of academic partners around the world, so that we bring together multidisciplinary and multinational teams together. Taiwan, India, Philippines, Uganda, Brazil, Colombia. So we have a great group of students, and we bring them together to work on actual projects. We had students representing 31 different countries, and we had 20 different projects that they were working on. edX, massive online. If you want to sign up, you can actually take the course next year. And then we also have a project incubator. Basically, this is exposing the innovators, the research, academic, clinical research, or social entrepreneurs to the global network, so they can actually try and create their innovation that they're interested in. These are a selection of the range of projects we have. A lot of different regions, as I mentioned, Brazil, Lebanon, India, a lot of different interventions. So this just kind of illustrates how flexible the platform can be, including dermatology, ophthalmology, oral cancer, pediatrics. A little map of where we are. Here's a picture of our oral cancer project. This is in India, screening for oral cancer within their population. It's going to be scaled up to 100,000 patients. This is our audio pulse project. This is in Brazil for infant hearing screening. So neonates, you want to screen for hearing loss by 6 months. So we're actually manufacturing or engineering a device, a hardware device, to interface with the phone. An ophthalmology screening triage program in Brazil as well. This is Partners in Health, if you're familiar with them. They have a large initiative within Haiti. This is their new Mirabelli Teaching Hospital. We have a post-surgical intervention app for that. We're in Kenya with Partners for Care. And then also South Africa for adherence, pharmaceutical adherence programs via SMS. So considerations for mHealth design, you really have to consider what the intervention is, what you're actually going to be doing. So whether it's data collection, screenings, or providing e-learning or guidelines. You also need to think about the users, who the various users are. You want to try and incorporate. It's customized to the intervention, but who's going to be using it? Whether it's going to be a direct-to-patient tool, or whether you're going to have the clinicians, or the nurses, or psychiatrists, or behavioral therapists, or physical therapists, or community health workers. It has to be customized for your solution. And you can have any user along the spectrum. So you might think about who's going to be collecting the data within that flow. Also think about the technology, whether it's going to be phone, tablet, SMS, text messaging, or voice recording. And then also you need to think, because I'm an informatician, I really think about what the informatics is going to be, what information you're going to be capturing, specifically because evaluation and evidence are really important and crucial. Because if you want to make it sustainable, you need strong evidence to get more funding to support your initiatives. And also, if you're in the business side, to sell it. You need to have some evidence that you're either saving money or saving lives. So some challenges with mHealth that you really have to think about. Technology, obviously there's cost, reliability, usability of these phones. Within the US, iPhone and Android, they're pretty stable and reliable, but within developing countries, you have your cheaper phones. You have to really be more cost conscious, and there are trade-offs with that. You have to understand the infrastructure. So mHealth is booming right now because there is wide coverage for wireless signals. So that's good. That's actually one of the strong drivers for mHealth growth within developing countries. Most importantly, you have to think about the systems. You have to think about the stakeholders and the various users, whether it's the practice model and workflows that's unique to the local environment, or the reimbursements and funding, the financing. Who's going to be making the money? Who's going to be willing to pay for this intervention? Interoperability from a computer perspective is important, so that's coding. It's also the information exchange, whether it's between clinicians or between systems. And there might be technology standards that aid that. I mentioned informatics. And then regulation and policy. You're all familiar with this and why the driver for e-health has been over the past few years. Obviously, HIPAA came in the 90s. The ACA, the high-tech, came recently in the past few years, really driving the EHR and e-health innovation. But within your local institution, you also have to be very aware of IRBs, obviously, if you're going to do any type of study or release anything new, and also the FDA, who regulates any device or basically or some apps as well. One thing to think about is privacy and security. This is kind of a fluctuating term. I'd love to dive into a little bit more about this. Happy to talk about more later, but basically they're actually distinct, and it's not just a set of standard rules that you have to follow. You've got your the workflow process, the desired versus the technology and encryption, and then also individual preferences. So from the patient perspective, what they want to share and what they don't want to share. So what I wanted to highlight a little bit is technotherapy, and the reason why this is a project that's going to be we're mentoring and supporting through SANA, and the greatest thing that it has is a real champion who's going to be, and for any project that you have, having a champion that's really passionate about solving that problem is going to be crucial to the success and sustainability of that project, and that's why we have Vikram here, and that's why he organized this event to really drive mHealth deployments within behavioral therapy. So as a final exercise before we transition over is, what are some needs that you might see within your practice or organization that might be addressed via an mHealth tool? 50% no show rate. Yes. Good.
In your Excuse me, can you repeat the responses?
Yes, she said 50% no-show rate is something to address. Which is a great point.
Community outreach.
Community outreach, good. Education, e-learning.
Walking jail, so we had that, how you, evaluations versus the cost of somebody going to the hospital.
Yeah, good. So basically evaluating the cost versus like going into the hospital for treatment options to analyze the cost effectiveness of a particular intervention. Good, excellent.